Hello, hi. My name is Dr. Mohammad Nakash, and I'm one of the internal medicine year 3 trainee working as a medical registrar at Skantop General Hospital. Thank you for letting us present this topic, which is basically finding borderline ventricular dysfunction in a young athlete. And we are going to navigate this gray zone between physiological adaptations, which can happen in young individuals um, who are having a very active lifestyle as compared to early changes in the heart, which can also present in someone who is having early cardiomyopathy. So um, we are going to distinguish how we are going to distinguish between the physiological cardiac adaptations happening in athletic heart syndrome, and how we are going to compare them with dilated cardiomyopathy. So in athletic heart syndrome, basically the ventricular dilatation and the changes in ejection fractions are relatively balanced, and the ejection fraction is preserved. Whereas in dilated cardiomyopathy, it can have overlapping features, but it will over a course of time, the patient will develop progressive dysfunction in their ejection fraction and their ventricular systolic and diastolic function, depending upon the type of cardiomyopathy. We can differentiate these conditions by doing advanced imaging, which we won't have if we are doing it as part of our general medicine or acute medicine jobs. It would be basically present in advanced cardiology specialty input, which include cardiac MRI, strain analysis, stress echocardiogram, and all those things which help us differentiate between these conditions. So we as internal medicine doctors encountered a 22-year-old male athlete who presented with some symptoms of atypical chest discomfort, palpitations, ongoing for last few weeks. His physical examination was normal. He didn't give us any history of drug intake, no history of alcohol intake. He has well controlled asthma with some bronchodilators, which he was not using that much. His ECG on presentation showed tall T waves and high voltage QRS complexes in V3 to V6. His troponins were negative and chest X-ray was unremarkable. Given his frequent football activity and we wanted to rule out some things, a cardiology referral was made for further evaluation. The important thing was that he had a family history of sudden maternal death at 54 years of age. Her mother passed away, unfortunately, and although the mother had a history of throat cancer and lung cancer, so an autopsy was not performed in order to evaluate for the cardiac causes of death. So we didn't had much information present from the family side of things. Um, Regarding the investigations, after the initial investigations, as I mentioned, of ECG, initial blood test, cardiac troponins, chest X-ray, we requested an echocardiogram for this patient, which showed a normal chamber size. His ejection fractions were 50 to 55% and GLS of minus 20%, which falls in the normal range. We ordered a Holter monitor for 24 hours, which showed sinus rhythm with rare ectopics and episodes of tachycardia and bradycardia. The worth mentioning thing is that the patient didn't had any episodes of any arrhythmias, which are more common in patients with cardiomyopathy as compared to physiological adaptations, which would happen in athletic heart syndrome. Um, this patient had a cardiac MRI, which unfortunately, due to some resource constraints, was done without contrast. It confirmed that he has got biventricular dilatation and he has got low normal systolic function. Because it was a non-contrast study, so we were not able to have any tissue characterization, unfortunately, in this scan. Um, this patient was referred to cardiology for follow-up in their inherited cardiac condition services. Patient was initiated on low dose bisoprolol for palpitations when we discharged him. We planned stress echocardiogram and cardiac MRI with gadolinium contrast to be done under cardiology services, and the plan was made for longitudinal follow-up for surveillance and risk stratification if this comes out to be a cardiomyopathy related diagnosis. So these findings actually were more consistent with physiological adaptation in this patient, but because given his family history of sudden maternal death at 54, we warranted to to do for some further investigations, which I mentioned. For this patient, when we followed him up, cardiology was planning to do a stress echocardiogram, and they were also planning for a cardiac MRI with gadolinium contrast. Stress echocardiogram, obviously, it would help to differentiate physiological adaptation from cardiomyopathy to after assessing the contractile reserve. When we give some stress, as you would know, in physiologic athletic heart syndrome, the ejection fraction and the contractility of the myocardium would increase as we increase the stress, while in cardiomyopathy the contractile reserve would be poor. Again, with cardiac MRI with contrast, we want to evaluate this patient for some fibrosis. Although I would like to mention that in his previous cardiac MRI without contrast, there were no features to suggest that this patient might be having cardiomyopathy. They were more positive towards athletic heart syndrome. Genetic testing and family review was again advised, given this patient had a history of sudden maternal death. This case actually underscores the diagnostic overlap which we just wanted to mention with this presentation between physiological adaptations of a normal heart and in early cardiomyopathy, and how we have to actually make this diagnosis of athletic heart syndrome. In simple terms, it is a diagnosis of exclusion. We would have to rule out other conditions before giving someone this diagnosis, especially when they are presenting with symptoms and when they are presenting with a positive family history of sudden death. Um, Key educational takeaway, as I said, how to differentiate between these two conditions. The first one is exercise stress echocardiogram, in which when you apply the stress, the heart's contractile reserve, the, which means the ability of the left ventricular ejection fraction to increase with exertion. This is preserved in athletic heart syndrome and physiological adaptations, but it would be blunted to different degrees in dilated cardiomyopathy. In the second investigation, most important, is cardiac MRI with the late gadolinium enhancement. So if there is no pathological enhancement with gadolinium scan, which gives us clues towards myocardial fibrosis and scarring, then it strongly favors athletic heart syndrome. While if it is present, late gadolinium enhancement is present, then it is a hallmark of many cardiomyopathies, including dilated cardiomyopathy. Again, as I said, diagnosis of exclusion. This athletic heart syndrome is a fundamental diagnosis of exclusion. You have to rule out other causes for these presentations while you label someone with this diagnosis. That's why, as an internal medicine doctor, when we reviewed this patient in our general medical setting, we didn't label him as someone who is having that, because he was still pending all other investigations before labeling him this diagnosis. I have attached this slide which gives a few key differences between athletic heart syndrome and dilated cardiomyopathy. As you can see, I'm not going to go through all of them, but most of the features which we mentioned in our patient are present on the left hand side for athletic heart syndrome, and less features present on the dilated cardiomyopathy side. That's why this patient most probably falls on the physiological adaptations caused due to his athletic lifestyle. Most of the references we gathered from these resources. This patient is very due soon, in very near future. He is due for his stress echocardiogram, repeat cardiac MRI with contrast, and his genetic testing and cardiomyopathy screen is in progress. We will chase those results, and we are planning to publish this in reputable journal. Thank you so much. If you have any questions, you can forward them to me.